A lot of people have been interested in my health recently. They've been saying, oh, how are you going? How are you feeling? And it's taken me a little while to realize, in fact, it's probably a barometer of, how's the project going, and really what are your thoughts about this? And I'm excited. I think most of you have seen me recently. I'm actually very excited. This has been a long road. It's been a lot of preparation. And I'm really very excited with what the project have produced and what we are going to go live with in a few weeks' time. I think it's far more integrated and far safer than we have just now. There's going to be niggly bits that aren't going to be quite as good as we want, and that's going to take a bit of time. But it's a big uplift, and I'm really excited of where we're about to go. I think you all know what MARS stands for, so it's medication management, but it's more than just prescribing. It's integration of prescribing with decision support across the entire product. It's anesthesia, so partly some of those home meds will come into the anesthesia circle. What's been given during our anesthesia will be in the record at the time that it's given, and then post-anesthetic, that transition from into the perioperative space will be very evident and very easy to manage. And it's also research. We've got a huge amount of data. We're putting lots of diagnoses and problems and lots of physiological parameters, and now a lot of medication and fluid and blood. And that's a huge resource that potentially we can mine for research support. Why are we doing this? Well, quite frankly, it's safer. And we've known that this has been safer since 2006. We're 10 years down the track. We're using an established product that is used throughout the whole of the USA, and it's shown benefits, and it shows benefits currently. So this is an established product. We're a bit behind the times. We need to get on board, and we need to make our system safer for patients. So we know that electronic prescribing reduces errors by 80% and serious harm by 55%. And in the States, there's about 500,000 medication errors that are avoided using this sort of system. So it's an established product, and it works. I think, as Stephen says, it really completes our IAMR, and a lot of those difficulties that we have as to why am I using this and why am I documenting here really gets completed or finished off when you start adding medications into it and you start seeing that immediate benefit. There's a huge amount of data and analytics that this will contribute to. And once we've started getting accurate data inputs, then we'll have better outputs and reporting, etc. And in the future, we hope that this will reduce costs. So we'll be able to do the stock take, we'll see what's been given, we'll see what's been administered, we'll direct people away from high expense medications towards equally efficient but less expensive medications. The build has really been building on what we have. It's been a 5-year project, Renee. Okay, this is the last piece of the jigsaw. And it's a statewide build. So some of my colleagues complain that, I can't do this and I can't do that. But that's because really this has to be applicable to the rest of the state. That we have a rapid rollout, that the PA is an exemplar site, and at the end of this year, Logan and Mackay will come on board. Then it's LCCH. And we've just heard recently that Redlands and QE2 will come on site next year. So in 2 years' time, Metro South will be live with this system. So clearly it's really important that the build now is suitable for the state, not just the PA. It's very much been clinically led. So huge number of pharmacists, huge number of nursing staff, small number of doctors have been integrally involved in this to make sure that the IT system is actually a clinical system. And we know that with previous implementations, it's really important that we have that clinical input from the design to the build to the testing to the implementation phase. And we have it with this. We've incorporated existing guidelines, both PA and statewide guidelines. And it's amazing how difficult that's been to try and actually put into the system, that people actually aren't aware there are statewide guidelines. And we show them a power plan based on statewide guidelines, and they go, oh, that's not how we do it here. But we want this to be safe for the state. When we've really built on this, we've thought of what's the lowest common denominator. Who are we really wanting to make sure are safe when they're prescribing using this? And it's probably not this audience. You're all experienced practitioners. And it's really the intern in the middle of the night. How can we make sure that their choices in the middle of the night are supported by this, are safe? How can we make sure the junior nurse administering that medication has the backup that he or she needs to be safe? The system brings legible, clear, clinically appropriate orders. Do we need to go beyond that? I mean, really, don't have to go very far to see scribbles and, half a tablet or one dose or whatever. There's a lot of interpretation of our medication orders currently. The system, clear. We've built out 60,000 order sentences. Some of you will have experienced that. So not only now do we have the drug, but also common doses, common frequencies built out. And really all the doctor has to know is, what drug do I want to prescribe? Pick. Gosh, how often should I give it? That looks about right. Pick. And then why am I giving it? Pick. The aim is that the right patient's going to get the right drug at the right time by the right route. And this is part of that. It's more than just electronic prescribing. I have that in MetaVision just now. I can pick drugs. But I think we would all expect electronic systems to have a bit more than that. A bit of intelligence, a bit of decision support. And there's quite a lot of decision support. And we've built out the system to a higher caliber than most US centers went live with. We've considered what drug-drug interaction do we want? And we've made that life-threatening at the time of prescribing. If this stops you prescribing this drug, you would want to get an alert. Not, in a few days' time, you may need to adjust this drug dose. We think the role of the pharmacists and the clinicians is there. We're just a bit worried that too many alerts will then start leading to people ignoring it. I think we've got that balanced right. We're using the pathology interface to actually support us at the time of prescribing. What's the creatinine? Oh, it's 200. Maybe I need to reduce the dose of this antibiotic. You'll see that at the time of prescribing. And in fact, even if you don't see that, there'll be a rule that comes in and says their GFR has dropped to less than 50 mils per minute, and you need to reduce the dose of that drug. So it's got a bit of intelligence there at the time. And we've built out maximum doses. If you ignore those order sentences and you choose to dose 2 grams of digoxin, it will come up and say, hey, that's too much. And that's partly to ensure when people aren't clear of the dose that they don't do the wrong dose, but partly also new errors, fat-fingered errors, an extra digit, an extra zero, an extra whatever. And we have all done that, I think, when we put our PIN numbers in or transferred money, as my wife did not so long ago. Anyway. So we've sort of carefully considered how we put that all together to make sure it's actually clinically useful. We've got real-time pharmacy verifications, so they can prioritize what the orders are in their area before coming to the ward. So they can see that that order has too high a frequency or too high a dose, or they're a bit concerned about that, and put a hold on it in real time. And that's far better than walking around the ward and discovering at 3 o'clock that this dose has been given a couple of times and it's too high for that patient. And we know that we cause harm with that currently on paper. There's a bit of graphing to try and support our decision support. And I think that's mainly in the insulin BSL, where we've got sort of insulin doses and BSL doses and ketone doses. And that required a lot of work. But there's a lot of sophisticated information and graphing that we can do to support our management of our patients. And of course, we've got power plans and guidelines. And some of you will have seen these. We've built out 80 power plans for Go Live. We've touched on some of the big areas across a lot of areas. And trying to incorporate medications and radiology and pathology into existing guidelines, build that out, and really support the management of patients within our hospital as per state guidelines. I think there's a lot of work to do, both to ensure what we have built actually works in the system, but also develop these. And I'm sure you can all think of 5 or 6 power plans in your area that would help the management of your patients and ensure that your juniors know how to manage that patient consistently. I've touched on the fact it's integrated, so you're not going to have to go 5 or 6 forms to find out how much fluid. You're not going to have to look at the ED trauma sheet or the anesthetic form or the fluid chart to find out how much fluid did this kidney transplant get. I'm sorry, I'm picking on renal. It's all going to be there in one place. Our anesthetic record and our power trials is all going to be there in one place. Our pathology and radiology is all going to be there in one place. The information you're going to get where you pick up the drug at Pyxis is going to mirror the information you get at PowerChart. And the information is going to translate from PowerChart to PharmNet to iPharmacy where it's dispensed. We've had some difficulties with those latter two, the interfacing and the mapping. We have got functional, but there's quite a lot of work to try and uplift those areas. That's been a lot of work. And it's not just the Cerner side, there's the interfacing and the messaging, and then also the output at the other side. And it's sort of been the bane of the last 2-3 months. We've got it working, but it's going to need a lot of work afterwards. There's clearly a lot of data, and those involved in research, there are tools now to use that data to find patients in the system that might be suitable for your trial. And if they're on the trial, you'll be able to see that when they come in the door. Maybe they're on a new medication. Maybe they're on something that you don't want people to interfere with. And the coordinators and the protocols will be visible at the time of admission for all to see. And I think that's tremendously advantageous to what we have. Decision support for antibiotic stewardship, immunization record, high cost and restricted medications. There's a lot of reports that we've built in. We've got some of these working, and some of you may be aware some of this is still requiring a little bit of work in the background. But really, what's the future? I think the future is you come in and you're 60 odd and your creatinine is whatever and your white cell's this and your temperature's up, and then we start directing people saying, hey, is this person septic? And then the E. coli comes through in the pathology and says it's sensitive to meropenem, and you get some messaging. I think we can make this far more powerful and far more specific to the patient with the data with time. And that would be really very exciting, wouldn't it? There is going to be an impact on you, though. You can't just get the pen and scribble something. You do need to be in the system. You do need to be familiar with the system. And I know some people have been struggling a little bit with training. It's a lot of new, different things. We'll support you through this. As you know, that the training is 4 hours in a classroom and then 2 pracs after that. But it doesn't stop there. We've got adoption and training and implementation teams to support the go-live process and support the process go-live. And we know that some areas are going to be a bit more tricky than others. I think a lot of people are a bit worried about outpatients and how that's going to look. And I think we can support that. And we want to try and support current activity and what you currently do, and then build on that with the future. Some elements are a bit clunky. I acknowledge that. But we have to go live at some point. I think we're ready to go live. I think this is safe and better than what we're doing, and will need a bit of work with time. And sometimes we need to let things play out and be in the system and learn from that before we can really tailor this to actually people's requirements. It's certainly safer. So we're going to have lots of paper forms that we currently have. You're going to have one place to look at that. You're going to have to click a few times to get round there, but the information carries through in multiple places. That will take a bit of time and adjustment. For modifying, is this the right chart? Is this chart 1 or chart 2 or chart 3? Is this scribbled, cancelled? Do I forget to rechart it? All of that will go away. One place for charting, for medications, for fluids, for blood. There's not really a lot of decision support at the time of entering it. You've got to look up things, you've got to be distracted. Whereas in this, all the decision support is in one place at one time. It's tremendously useful. And you've still got the safeguards of those armbands, but in fact, you barcode the armbands. It's a bit more intelligent than just the visual reminder. And we're not suggesting this should replace those other safety mechanisms. This is in addition to what we currently do. We are quite concerned about alert fatigue. You know, we could overbuild this, over-engineer this, and we know if we do that early, then you'll forget and you'll just ignore all these alerts. I've had that bit in ICU. You switch off to the little dings and then you tune into the big dings. And we've learned and looked at the experience both nationally and internationally at this and tried to make it as tailored and as meaningful as possible. I think blood and fluids, you know, that's always difficult to work out how much fluid someone's had. We'll have an accurate fluid balance. We may find it's actually more accurate than we anticipate. You know, is this patient really 1 or 2 liters over? That's certainly my experience in ICU. We're using electronic systems. Complex meds, I think, is really where electronic systems come into their own, where we have that piece of paper that has 3 or 4 sides, a lot of information, and you've got to go to various parts within that piece of paper and work out what we actually do for the patient, how much insulin to give, how much heparin to give, how much warfarin to give. And we know that this is where people make the most mistakes, and it's probably where we have spent the most amount of time developing. Insulin paper form took 10, 15 years to get to the current state. We spent a good 6 months with the electronic version. We spent far more time on this than anything else. Is it right? I'm not sure. I think it will certainly support the current activities, and there are elements that are good and elements that are not so good. It's certainly safe and will require a bit of time. Heparin. Heparin, we're going to go from units per kilo per hour, which is the state guideline, to ordering units per kilo per hour, to administering units per kilo per hour, to seeing units per kilo per hour on the syringe driver. Sounds like a no-brainer, doesn't it? You have 1 unit of measure and your adjustments are made based on that 1 unit of measure. That was a huge amount of work from, you know, pharmacy, from devices, from our nursing staff, our medical staff, and then a huge amount of work to support weight-based dosing within the system. But it kind of shows that we can use the system and use the computer to do a lot of those built-in calculations based on the actual patient, not just based on a generic system. So if you're 65 kilos, the dose will get calculated and then populated. The room for error should be much less in terms of the human factors. Discharge scripts, we should be able to support that the inpatient medication can then be converted to an outpatient script. We'll then have documentation in the system automatically as to what was charted. I think that's one of the concerns. I got a script for this doc, and there's really no record of that currently. In the system, you will see what they've had scripts for previously. It will populate their home medications. So we're going to build up with time a lot more information about what medications the patient is usually on from their GP when we update it, and the medications we actually discharge people on when they're here. And I think that will be tremendously useful with time. We can then convert those in the inpatient space and the outpatient space using reconciliation, and some of you have probably seen that. PBS coding comes through automatically and then gets printed out and signed off. And we've done a lot of work in socializing these new printouts within this institution and within the local pharmacies and within the local hospitals. Home medications, I think, is an area that we will build on. I think a lot of people are feeling anxious about home medications, about the amount of work to document home medications. My take is we support current practice. If we document the current home medications, we continue to do so. If we're not doing that, then this is something that we build up with time. It's particularly useful for patients transitioning from outpatients to inpatients or inpatients to outpatient space, and that's really built in. Those that are coming as consults, I think, will have to be based on what is your current practice. And there'll be some patients, like the chronic renal patients, where it'll be really important to have that list, and often their meds are actually prescribed from here. But there may be other patients that are mainly being managed elsewhere, which will need to be built up over time. And that when Metro South is completely IEMR in 2 years' time, that's clearly really a target time where we'd want those home medications built up for those patients. because it's much more meaningful. So where are we up to? Well, I think we're 4 weeks out, and I'm excited. We had a technical cutover last night, which is when we started the metamorphosis of R3, which is what we are currently, into R4. So there'll be some elements you see today that are really reflecting R3, and there's been a bit of comms about that. In the next 4 weeks, I think Cerner are going off to build everything and making sure it works. And then on the 19th of March, we have the go live sequencing, and we'll show that in a second. What do we need you and your colleagues and your juniors to do? We'll need you to get trained. We've got 4 weeks to go. We know there's been a bit of a delay in people coming to training, that it's been put off once and then twice, and I'll forget everything. But we really, really need you to book in now. We are a bit concerned that we've got about 400 medical staff that need to be booked in and trained before go live. And we're a bit concerned that if this ends up all being in the last week or two, we'll overwhelm our resources. We've got lots of resources, and we've had them since November, but we need to do a bit of planning. We need you, your juniors, to book in now. And we can do that just now, and we can do that, anywhere. There's been a bit of concern about, what training do I need to do? Our trainers know this. And essentially, we need to take you through the fundamentals, and those using complex meds need to do the complex meds. We believe a classroom session isn't enough, that you need to play and practice in the session. I think those who've been through the 4-hour session will recognize that. I see there's a few nods. Our go live sequencing, hopefully you will have seen. I really need a much bigger screen. But the gist of it is we have 5 wards going live on Sunday the 19th. So 3 on level 5, A, B, and C, 2A, 2B, and the mental health high dependency. We're going for what is a big bang. So we're confident in this product. We're confident in the rollout. We're confident it's going to work. And we want to get people into the system and using the system and not having a hybrid system in as short a period of time as possible. So essentially in the first week, it's most of the wards. A lot of people on the Sunday. It's then the operating theatre on the Monday, so we've got a bit of time to consolidate the wards, and then a rapid rollout of the wards in the first week. EDs in the second Sunday, and then progressively outpatients, procedural areas, and eventually middle of the third week we should all be go live. Where's the information? Well, there's lots of information on QEPS and on the Innovate PA. Lots of resources here, a lot of what are called quick reference guides. How do I do this? There are hundreds of them. They're very simple. They're very concise. Any questions? Feel free to email me, call me, ask me how I'm going. Thank you for your time.